Sir, can you hear me? Hello, Devesh sir, can you hear me?
People are doing it. So what is the volumes you are using regularly?
Hello, Devesh sir, can you hear me?
The volume they are saying, sir.
Okay, so 15 to 20 ml is a good volume. For anesthesia, use 0.5% ropivacaine or 0.5% levobupivacaine or bupivacaine.
Hello sir,
And
we are ready with the
anesthesia,
second case. Can you hear me?
0.5% ropivacaine is sufficient, and you can cut down the volume to 8 to 10 ml. Is it okay? So, ready. Okay, fine.
They are showing the PEC block.
PEC. Okay, then we demonstrate afterwards PEC.
Hello sir, yeah, we are ready with the second block. Can we start? Can you hear me?
No, 4 is okay. 4.
We are ready. So, can you please brief us about the patient?
Yes, sir, sure. So this is a 64-year-old female with right intraductal papilloma, and ma'am will be, this patient is posted for microdiscectomy, and ma'am will be demonstrating interpectoral and pectosartorial blocks.
Serratus.
Pectoral, pectoserratus.
There is a small voice break, so can you please repeat the description of the patient?
Sure, sure. This is a 64-year-old female with right intraductal papilloma, and she's posted for microdiscectomy. So ma'am will be demonstrating interpectoral and pectosartorius blocks.
Serratus.
Serratus blocks.
Hello, Dr. Divesh, can you hear me?
Bitidian?
Yes, doctor.
Yeah.
Dr. Divesh, can you hear me?
Yeah, your voice is cracking in between.
Okay, that's fine. We'll update in here. Okay. Please see the voice is cracking.
Maybe, sir, you can demonstrate. We will show from here only.
Sorry.
Sir,
That's okay.
hello, Dr. Divesh, can you hear me?
You can make it vertical also, not an issue. 2D.
Now it's better. So I just wanted to.
Chalega, better.
So, Dr. Neeta, please start.
Just Dr. Divesh, I just wanted to give one input. We have this TCI pump which we used with remifentanil in the last patient where the patient had very poor cardiac condition. And in these patients, TCI with remifentanil is a boon where you do not need to handle the airway. So that's the one input I wanted to give. And we are going ahead with the live demonstration by the block by Dr. Neeta. Thank you.
Anjuman sir, the voice is cracking. Your voice is cracking. We are not able to, what you are saying. But we can infer that you have started the remifentanil infusion in this patient. And can we please zoom out a little bit so that we can show the economics to our delegates for giving the PEC block?
This is visible. Good morning, Dr. Devesh.
Good morning, Dr. Neeta.
Please zoom out a little bit.
So, do let me know if things are not clear.
I think you start, Neeta, explain. Please start
Okay.
explaining.
So, I will be explaining the interpectoral, which is the PEC1 block, and the pectoserratus. So, this primarily is for the anterolateral chest wall. With regards to the patient positioning and ergonomics, I'm at the head end of the patient, and the monitor is facing me. So, the needle direction in this intentionally would be craniomedial to caudolateral. So just to show you the position of the patient, the hand is abducted and I am starting at the clavicle. So you can see the shadow on the left of the screen. The left of the screen is cranial and the right side is caudal. So if you can see, I've placed the probe somewhat perpendicular to the clavicle. This is seen.
Yeah, we can appreciate.
Yes, so from there I'll be slowly moving towards the axilla, and keeping in mind I'm going to locate the pectoral muscles as well as the second rib and subsequently the third rib. So the first two muscles over here which are visible is the pectoralis major on top. Okay, they've just asked me to hold for a while. Okay, I'm resuming. So as I said, am I audible?
Yeah, you are audible.
Okay, so this is the clavicle on the left side, if you can mark it, yes. And as I slide down towards the axilla, I can see the axillary artery actually below there. So above, there are two muscles which have appeared. The one on top is the pectoralis major. The one below is the pectoralis minor. If you can appreciate a small vessel, markings just, we'll take that out. Okay, can you appreciate this vessel over here between the pectoralis major and minor? So this is the pectoral branch of the thoracoacromial artery, which is an important marker for identifying the neurovascular plane. So what we are targeting here are the medial and lateral pectoral nerves. So in close proximity to this, if the facial plane opens, it should suffice, and our target structure should be covered. So this would be the third rib as I go down, and you can see the slip of the serratus has already started over the rib. So how do I know it's the below the pectoralis minor and the rib? You can see there's a thin muscle which have started appearing. So it's usually at the level of the third rib that this facial slip starts, and the muscle thickens as we go towards the axilla. So are you able to appreciate the two layers, two planes? So the pec major, minor. So in between that, I'll be terming that as interpectoral rather than pec 1. And between the pectoralis minor and the serratus as the pectoserratus. Right? So now with regards to needling, the drug which I have taken, since I'm giving a pre-op block, I have taken 0.25 ropivacaine. I'll take it. And needling would be in plane. So a few tips and tricks is, as I am needling from Kefalat to Cordad, preferably the head should be turned and the to the opposite side. Okay, now my needle is pretty much in the pectoralis major. So what I practice is with regards to what Dr. Rafael Blanco and all had devised, they have taken two separate injections, one for the interpectoral, which is higher up and close to the thoracoacromial arteries branch, and one a little lower down in the axilla. But a lot of breast surgeons have concerns with regards to certain puncture marks which cause discomfort and concern to the patient. So what we follow is like a single puncture to achieve the same and inject between both the planes. So now I've got a pop. 1 minute, I'll show you the needle better. Now the trick over here is it is slightly oblique. So to get the entire length of the needle, now you can see the plane. So I've got my first pop, but I don't choose to give the injection now because I want to give the distal injection first. Yes, I've got the pop there. Is the needle visible to you all? Yeah, just aspirate. Negative. Just 1 or 2 cc, half a cc. Yes, yes. So very often there can be a slight intramuscular, so you must give it in very small aliquots. So I'm just going to reposition it a little bit and come back to the plane above. Yes? Okay, so the plane, so it is more like an unzipping in this plane, and once a pocket is created, you can actually take the needle slightly lower down and ensure that the entire plane is open. So this is a volume-based block for sure. volumes ranging from 20 to 40 ml have been used. I use around 25 ml. Yes. So here I'm injecting 0.25 ropivacaine. So around 20 ml is given. I can further move in the pocket. Yeah. The same plane of the pectoral serratus is what follows as the superficial serratus plane block, which I will show you lower down in the axilla. Yes? So again, the unzipping has actually stopped. So let me just see where. So over here, a good thing to do is, locate the pleura, few tips and tricks. Make sure that you're not close to the pleura. A good thing to do is target as if you're going to the rib. That's much safer versus targeting in between the two rib spaces. So this is around 25, 30 ml of the drug. Now what I do is I come back and now I open up the interpectoral plane. So I've got a pop. Again, sometimes it overshoots and goes into the pectoralis minor. Half a cc? Yeah. So you can see the plane again opening up, a good unzipping that is being achieved. Yeah. So around 10 to 12 ml is ideally more than sufficient if the pectoral branch of the thoracoacromial is located and you are just next to it. Even 8 cc would suffice. 10 ml? Yeah? Okay. So this is with regards to these two blocks. As I said, tips and tricks for this would be to get one single point where you see the start of the serratus. So as you can see, the serratus over here has thickened. The pectoralis minor is almost thinning and will gradually disappear here. Sorry. I'll show you in the axilla. Now the block is over, so I'll sorry. So as you can see, she has a huge pad of fat. So the needling, if it is for the superficial serratus, may be slightly difficult. Now, my probe is held vertically. So I can see the rib over here. So this is the rib. I can't. Sorry, and the pleura in between the two ribs. If you see the muscle over the rib over here is the serratus, and as I move posteriorly, you see another muscle which is coming up, which is the latissimus dorsi. And is a vessel over here appreciated? Can you all appreciate this vessel over here? I'm just freezing the screen.
Yes, ma'am.
Can you get my glove out? So this is what I had. This is a frozen image. So this was the pleura. This is the rib. This is the serratus. This muscle is the serratus. This is latissimus dorsi, which thickens as I go posterior. This is cranial, and this is caudal. Or rather, anterior and posterior. Not cranial caudal. This is anterior, because I'm holding the probe parallel to the rib. And just observe this structure over here, which are the thoracodorsal vessels, which supply the latissimus dorsi. So I'm just getting this off screen. So is that vessel appreciated over there?
Yes, ma'am.
Are you able to appreciate that vessel, Divij sir?